They assess the implant stability, the bone stock, infection for selection and treatment, choosing between the operative and non-operative management, and when to do revision, arthroplasty, or endoprosthesis, apply fixation mechanism, stem revision principle, post-operative protocol, and failure prevention. So, when we have a pre-prosthetic fracture, I want you always to think around these four question algorithm. Where the fracture happened, when we are talking about the hip, around the trochanteric area, around the stem in the metaphyseal, or distal to the stem in the distal femur, in the total knee, around the distal femur, tibia, or patella, or when it's happening intraprostatic. The stability of the stem, either the femur or the tibia, the bone stock equality, which will help us after that if we can do a fixation or if we're going to revise it. The patient, if it's fragile, infection, mortality, and the risk for anesthesia. After these four questions, we can apply our plan. So, when the stem is stable, we always going to do osteosynthesis, or if using a blade, nail, whatever in our hand. If the implant is loose, we are going to revise it in strategies based on the algorithm we talked about before. Poor bone stock, augmentation, megaprosthesis, or salvage. Why pre-prosthetic fracture are different than normal fracture? So when we are talking about the pre-prosthetic fracture, keep in mind that there is a stem where arthroplasty team, and you have to think like an arthroplasty surgeon, and combine it with the urotrauma skills and as orthopedic. So most of the fracture happening to the elderly patients where are low demand or having arthroplasty, there is a comminution, osteoporotic, short working segment, limited screw option because of the stem and the cement, and you need to do early mobilization. This is for the fracture itself, and when you are thinking like a trauma patient, doctor. The arthroplasty problem itself, the implant loosening, or if there is occult fracture or infection, bone loss and osteolysis, restoring the biomechanical offset and the stability of the stem, implant availability, and backup plan. So, right now, we are going to assess the pre-prosthetic fracture with the history and radiographic, implant stability, and infection workup. So, when you are going to take a history from a patient with a pre-prosthetic fracture, often pre-prosthetic fracture till it's solely itself, when there is pre-fracture pain around the stem, this is always keep it in your mind like a red flag because pain starting in the hip or the groin, progressive with weight bearing, could be an occult fracture caused by early loosening of the stem or by infection. Primary or revision surgery, you have to ask always, stemmed or uncemented. The system, stem design, and fixation method. Previous infection, wound problem, revision surgery, osteolysis, or radiotherapy. The mechanism of the injury, if it's low energy falling down, high energy trauma, spontaneous fatigue fracture, intraoperative events, baseline mobility, cognitive status, fragility, anticoagulation, and if there is an open fracture or a neurovascular statement, you have to assess it also. The imaging study. Plan radiographic first. You have to do it for your all patient. As we know, you have to do AP lateral, the whole limb, which is including femur and hip for the total hip. And for the total knee, AP lateral, full length of the femur and the tibia when needed, and the patella views. Try always to compare it with the previous radiographic. The stem subsident, component migration, ludolucent line, or osteolysis could be a hint for you if there is an infection, sudden infection happening. CT scan with metal artificial reduction helps define the fracture morphology, bone stock, implant rotation, and occult extension. Templating the operation. This is a you have to do it always. because you want to know the length of the plate, the distal stem fixation, screw erosion, and if you need a cable, allograft, or sleeve and cones, or megaprosthesis. So when you have a preprosthetic fracture, always think about infection. Do not revise or replace if you don't have unrecognizable PIG. When to suspect infection. If there is a pain before the fracture happening, early loosening or unexplained osteolysis, sinus, wooden, sinus wound drainage or previous PIG, systematic symptoms or immunosuppression, revision arthroplasty history. The workup that we always use is CBC, ESR, CRP when suspect exists, aspiration if feasible and management challenge, multiple intraoperative culture in revision cases. Sometimes we use a frozen section and synovial biomarkers by local protocols, plan strategy surgery if infection is confirmed. Pre-prosthetic fracture, femoral fracture after total hip. So I think all of us know the Vancouver classification is one of the most useful classification of the pre-prosthetic fracture directly linked to the treatment. So Vancouver classification is, like we say, there's multiple types of it. AG around the trochanteric, if it's stable with a adequate bone stock, non-operative or trochanteric fixation can be used. If it's around the lesser trochanteric or the calcar, assess the stem stability. If there is a good bone stock with a stable stem, you can be non-operative treatment, treat the patient. B1 and B2, you have to see the stem happening around the stem. Depends on the stem stability. If it's stable with adequate bone stock, do ORF. If it's unstable or loose with adequate bone, do revision with ORF. Around the stem with loose stem and poor bone stock, revision, reconstruction, or megaprosthesis, depend on the bone stock. C, a distal to the stem, where you have to do ORF and protect your stem. How to judge the stem stability? So, stem stability, suggestion for stem stability, loosening, pre-prosthetic thigh or groin pain, subsident or varus migration, where, and you have to see the old film, progressive ludolucent line, cement metal fracture or debalding, fracture disruption, the fixation zone, proximal comminution or osteolysis. The practical rule, if the stem zone is fractured, be suspicion. All radiographic with extreme variable. CT scan help, but doesn't replace the surgical judgment. When uncertainty expose and directly test the stem, have revision implant available before the incision. Vancouver A fracture, trochanteric fracture are treated according to displacement, adductor function, and stem stability. The subgroup of the A is the greater trochanteric or the lesser trochanteric, typically management with non-operative if there is no displacement with the adductor or functional working. For the greater trochanteric, we do operative management when the migration happening, adductor insufficiency, instability, painful non-union, or large osteolysis. The lesser trochanteric, large calcar fragment or extension compromising stem stability. The fixation in this kind of a fracture are circular wire, cable, hook plate or clown plate, adding bone graft on osteolytic defect. Vancouver B1. The stem is stable with adequate bone stock. It treats the fracture with stability, biological osteosynthesis. The gold standard is long lateral locking plate spanning the fracture and the stem region. Bicortical fixation where possible. unicortical locking screw and cables around the stem, bridging communi- preserved soft tissue and medial fragment, restore length, alignment, and rotation, avoid varus or malrotation, avoid stress rising, overlapping stem and plate, protect the implant tips. Consider adjacent dual plate, medial suture allograft, and cable plate or attachment devices in selective patterns. B1 fixation mechanism. Think of the working length and screw distribution and the medial support. So when you are trying to do it, try to apply these principles. The plate length, the proximal fixation, distal fixation, medial column, and biological. The length of the plate, try to use a longer plate, bypassing the stem tip and the fracture to avoid short stiffening construct. Proximal fixation, use cable, unicortical hook plate or locking screws, attachment the plate wherever needed. Distal fixation, multiple bicortical screw with a spread, avoid all screw near the fracture. Medial column, try to reduce it and reconstruct it. And biological, try to not disrupt every fragment. Vancouver B2, stem is loose with adequate bone stock. Revision, always the standard. The revision goal is remove the loose stem and the cement as needed. Obtain the fixation distal to the fracture. Bypass the fracture with long revision stem. Restore the length, offset, and the stability. Use cerclage and plate to reconstruct the proximal tube. The common implant we're using is tapered floated modular stem on monoblock tapered plated stem, long cemented stem selected in elderly cemented cases, calcar or proximal body replacement if needed, cable and plate adjacent when the fracture stability is required. There are some cases where controversial that B2 should be, we can use just an ORF in it. Why we are just using ORF, but the gold standard for it is revision? Because sometimes the patient is fragile and cannot tolerate a major revision surgery. Some cemented polished stem subsided but remain functionally reduced. When we have intact lateral cortex patterns, maybe mechanically flavored, RF can reduce blood loss and the operative time. Why revision remain deferred? Through loosening, risk non-union, or plate failure. RF does not solve implant instability. Selective bias retrospective studies have shown that still the revision is the gold standard. Vancouver B3, when there is the bone loss and the stem is loose, reconstruction or replacement. Assist reminding diaphyseal bone can be distally stem fixed or achieve durable stability or not. Use a long tapered floated stem plus cable and plate when the femur can be reconstructed. Add cortical sutured allograft or proximal femur reconstruction for major bone loss. Proximal femur replacement when proximal bone is non-reconstructible or immediate stability is required. Total femur replacement is rare salvage or bone loss, failed fixation or revision, like a tumor defect or infectional consequence. Vancouver C, whereas the fracture is distal with a stable stem, treated like a femur shaft or distal femur fracture, but protect your arthroplasty. Confirm the stem is stable and the fracture is truly distal to the zone of the fixation. Use a longer plate, lateral plate fixation, overlapping the femur stem sufficiently to avoid stress riser, bridge the comminution, and preserve blood supply. If the knee arthroplasty is present, treat as intraprosthetic fracture and protect both implant. Retrograde nail only can only if the knee implant allow it and the fracture level is suitable for it. Intraoperative total hip replacement femur fracture prevention and immediate recognition is better than postoperative desert. So most of it happening in the calcar area or trochanteric, diaphyseal crack or unstable stem. The calcar crack, when you see it, just use a cerclage or cable fixation and confirm the stem stability. If the trochanteric fracture, fix it if it's displaced, unstable, or adductor compromised. Diaphyseal crack or perforation, bypass with a long stem or use a cable or a plate. Unstable stem after the fracture, revive the stem immediately. Do not accept compromising the primary fixation. So let's now talk about the preprosthetic fracture happening around the total knee arthroplasty. Total knee arthroplasty fracture, the distal femur is the most common site after total knee replacement. The risk factors are osteoporosis, anterior femur notching, revision total knee arthroplasty, inflammatory arthritis, neurological diseases, or chronic steroid users, or falling down. The key discussion component stability, distal femur bone stock, implant design, the level of the fracture, and the extensor mechanism function. The treatment choice, non-operative care, locking plate, retrograde nail, revision, and distal femur replacement. Lewis Bracken classification is high yield for distal femur classification after total knee. The type, they have three types, type 1, 2, and 3. Type 1, non-displaced. Type 2 is the displaced, and type 3 and displacement. The component is stability, and type 3 is loosening or full component. The treatment depends on the stability and the displacement. When type 1 is non-operative, but fixation is still depending in some patients. Type 2, ORIF and with the locking plate or retrograde nail. Type 3, revision the total knee arthroplasty or do distal femur replacement. SU classification helpful to choose the plate versus the nail of revision. SU depends on the fracture location and application. In type 1, proximal to the femur component. When it's proximal to the femur component, you can use the nail or a plate when there is sufficient bone stock you have. Originally, type 2, originally at the proximal aspect of the component and extended proximally, usually locking the plate, nail if the box allow, and the distal fixation adequate. Type 3, distal to the upper edge of the component and going very distally, locking a plate or distal femur replacement depending on the bone stock and the component stability. The distal femur treatment algorithm we can use is the distal, where is the distal femur fracture? Doing a radiographic and CT scan to assess the component and the bone stock, where it's the fracture line, and see the stable component or not, if it can be fixated or not, and the bone stock. Locking plate is devastated and the working with most total knee design. Retrograde nails requires open box femoral component suitable to entry and enough distal segment. Distal femur replacement treats fracture healing for immediate implant stability. Locking plate for the distal femur is the workhorse when the total knee arthroplasty components is stable. Using long lateral distal femur locking plate, bridge the community and preserve biology. Obtain multiple fixed angle distal screw with the medial fixation when versus risk is high. Avoid varus malreduction and short construct. Check sagittal alignment carefully. Extension deformity is common. Consider dual plating or nail plate combination in osteoporotic, medial comminution, intraprostatic, or high risk cases. Post-operative weight bearing depends on the fixation quality, bone, and the patient reliability and the institutional protocol. Retrograde nail after total knee arthroplasty is a good option, only when the anatomy and the implant design allow it. The requirement for it to use it is open box femoral component, entry point accessible and correct. The fracture is not too distal, enough distal segment for interlocking the screw, non-ipsilateral hip stem blocking the nail path. The advantage of it, it's loading sharing construct, less soft tissue strapping, may allow early weight bearing, cannot treat it, lose stem component, risk of malalignment or short stem segment. Distal femur replacement, salvage reconstruction tools, not rudely fracture implant. The best indications for it, loose femoral component with poor distal bone, severe comminution, and non-reconstructible distal femur. Elderly low-demand patient needed immediate stability, failure fixation with the bone loss, tumor-like bone deficiency. The major risk for using it is infection, aseptic loosening, extensor mechanism problem, instability, dislocation from the hinge mechanism, high cost with a complex revision if it's failed. Try to avoid the distal femur replacement, non-union, but replace it with a mega prosthesis is a complication. Pre-prosthetic fracture that happening in the total knee arthroplasty around the tibia. The flex classification classified around the location and the implant stability, where it's classified to four types, 1, 2, 3, and 4, which is type 1 is around the tibia plateau region. The treatment option, fix it if it's stable, revise it if the component is loose. Type 2, adjacent to the tibia stem, often fixation versus revision stem depending on the stability. Type 3, distal to the prosthesis and the stem, treated as a tibia shaft fracture. Type 4, tibial tubercle, extensor mechanism, falls, focus on the fixation if displacement. Patella preprosthetic fracture, the early extensor mechanism and component fixation matters the most. So there are three types. When the extensor mechanism is intact, the patella component is stable, typically the management will be non-operative. If there is a disruption in type 2, the extensor mechanism with a stable or loose patellar component, repair and reconstruct the extensor mechanism, plus minus component management. Type 3, intact, the extensor mechanism, but a loose patellar component. Component removal or revision depends on the bone stock. Type 3 and B depends on the bone adequacy. Do not chase a perfect patellar radiograph if the extensor mechanism is intact and the component is stable. So there's some kind of special situation where intraprosthetic fracture and osteoporosis and complication and rehab. Intraprosthetic femoral fracture between ipsilateral hip and knee implant. Avoid the unsupported bridge. Assess both implant, the hip stem and the knee component. Maybe one is unstable or one is loose. Short segment between the implants behave like a stress riser zone. Long blocking plate should be spanned over both implant when possible. Use cables, unicortical screws, plate attachment, locking plate attachment, or dual plating, depend on consider. If either the implant is loose, revision stages must be addressed the implant. Bone loss or very short segment may require endoprosthesis reconstruction. So when you are treating this kind of a fracture, look for the bone health and optimizing the patient, not just treating the fracture of today. The preoperative issues, the delirium prevention, and the geriatric co-management with the medical team. You have to consult them, nutrition and albumin and vitamin D, anemia, diabetes and renal functioning. And you have to see the coagulation profile, give him some prophylactic. The secondary prevention, do DEXA scan, osteoporosis evaluation when appropriate, give him a good medication based on the DEXA scan, anti-resolvable and anabolic therapy per bone health pathway, review the medical and cause of the fall. Complication, you have to predict it, and the failure of the mood. The complications could be the non-union, plate failure, dislocation after the revision, infection, and refracture or stress rise. So when we have a patient that have periprosthetic fracture that you operate on it, then came back with a non-union, think about the biological strap you have done, unstable construct, or loose implant. Try to not to detonate it with the prevention of preserve blood supply, correct implant stability, bridge wisely. When the plate is failed, because it's a stiff or short construct, varus, poor medial support, try always you are going with a long plate, balance fixation, and medial column strategies. The dislocation happening after the revision, it's because the offset revision or soft tissue tensioning error. Trial of carefully, restore the biomechanical, and use appropriate consult. Infection, which is occult PIG could happening because of the revision boundary and fragility. Screening, culturing, meticulous technician, and optimize the host. Refracture or stress riser and a protective implant tip or in the plate, overlapping the implant and avoid gaps. Post-operative protocol weight bearing should be intentionally, not autonomic. Early mobilization is critical in frail patient, but must match the construct stability. Revision stem or distal femur replacement may allow early weight bearing than fragile osteosynthesis. Locking the plate protocol vary. Tip touch, partial or weight bearing as tolerated depends on the construct and the bone and the reliability. DVT prophylaxis and delirium prevention, nutrition, and pain control are a part of the fracture treatment. Follow up radiograph until the union, which for progressive virus, watch out for progressive virus, implant migration, and hardware fatigue. So, case, so I will present to you one of our cases, which is a 60 years old male patient presented to us with this kind of a fracture. He's done his arthroplasty 7 years ago. So anyone can give me a comment about this X-ray?
الله يعطيك العافية تريدون. Thank you for sharing this case.
So حدا من الشباب يحكي لنا شو رأيه فيها.
شباب
Really,
سنراجع.
أعطيني كومنت عنها.
see, this is a plain digital radiograph shows a patient with total hip replacement showing periprosthetic fracture around the stem يعني.
شو رأيك يعني هي ماشية مع إنه good bone stock ولا ما في bone stock عند المريض؟
لا poor
around the
bone
stem,
quality.
bone quality. يعني انت بتحكي عن بي 3. سو انت شايف الستيم حاسه ستيبل ولا لا؟
ستيبل السم سيدي، ستيبل يعني بي 1 هاي موستلي.
most likely بي 1.
بي 1
اه
ستيبل and good bone stock.
good bone stock, yeah exactly. هذا
بس
المريض حطينا له لونج بلاي.
just
شو
need
رايك المانجمنت، شو بدك تسوي له؟
ورايف عرف.
آه.
يا يعني وكمان دبل تشيك انه بالانترا اوب انه ستيبل ولا لا. اذا ستيبل جو وذ عرف.
Yeah, exactly. This is the key point of it. If it's stable, intraoperative, go with oral. If it's not stable, revise it. So هذا المريض هاي صورته بوست اوب، اشتغلنا لونج هوك بليت سيركلاج اي كيبلز، ديستال فيكسيشن كان له، اموره تمام. So هاي الهاي للمحاضرة. في عندكم أي سؤال شباب؟
دكتور يزن، الله يعطيك الف عافيه، شكرا لتواجدك معنا اليوم. اذا
فيك
في حدا
حبيبي.
من الشباب عنده اي استفسار بيقدر يبعث للدكتور يزن او بحب يصير الان. وان شاء الله ملتقانا الاسبوع الجاي في نفس الوقت في محاضره جديده برضه مع ارثوبلاستي. يعطيك